I would like to welcome you again in this scientific program, but we need to take just a few minutes of your valuable time. For those who don't know me, I'm Fahad al-Shehri, President of Saudi Dental Society. We are partners and long-term strategic collaborative partners with the Ministry of Health. And we are so glad to partner again in this scientific meeting. We would like to take a few minutes just to thank one of our exceptional employees, Mrs. Emma Simpson. She has been working in Saudi Dental Society for 25 years as the scientific coordinator. She spent majority of her career serving the society and serving the dental profession in Saudi Arabia with all dedication and all loyalty to the Kingdom of Saudi Arabia and to the Saudi Dental Society. Mrs. Emma, we thank you so much for all of your efforts, for all of your dedication, for all the loyalty, and believe it or not, she's working in the nights, late nights and weekends, effortlessly, and she was a perfect example for a devoted and dedicated employee. She decided to retire and go back to the Philippines. Although you will leave us in the society, but we will still remember you with all the good memories that we have with you. And when you come back to Saudi, please stop by and say hi to all of your beloved friends in the society. All the presidents and the governing boards before us, they know how devoted and how dedicated Emma is. And all scientific meetings, all exhibitions, she is one of the people working behind, faithfully and sincerely. We can't thank you enough, and we will still remember you as one of the best employees we have in the Saudi Dental Society. So thank you very much, Mrs. Emma. And just to remember us, we will give you a trophy from the Saudi Dental Society. I kindly ask Dr. Abdullah Al-Amri, the board secretary, and Dr. Muhammad Al-Shehri. Dr. Muhammad موجود؟ لا للأسف. Dr. Abdullah Al-Amri is the board secretary with us in the Saudi Dental Society.
In 1999, her master's degree in dental public health at Boston University, USA, from 2004 to 2006, and Doctor of Philosophy at University of Alberta, Canada, in 2016. She previously worked as head of Hawali School Oral Health Program from May 2003 to June 2004, and head of Capital School Oral Health Program from September 2007 to June 2004. Sumait published researches in referee journals. She submitted abstracts to different international meetings, and she was also invited to give a presentation from local to international meetings. She's also a member of different professional organizations and associations. Please let us all welcome Dr. Aisha Sumait.
Thanks thanks for the introduction, and thanks for being here for all the organization committees and those who are here sparing their valuable time with me today. So my presentation is the second part of School Oral Health Program, and I would like to thank actually Dr. Al-Bandari. She spent a lot of time in health promotion, and she just did a great job that I will not go and repeat what she have mentioned. So I'll go through the theory very quickly, and then I'll spend more time in the results and details. For those who have no idea about the School Oral Health Program in Kuwait, I'll go through the introduction, how the school was established, school oral health program established in Kuwait, the evaluation that the questions, the research, the projects, methods, finding and conclusion, and the implication and future consideration. So, as you know, Kuwait is a small country than your neighbor there, and the 3.6 million live in Kuwait, 1.2 nationals, and we have 2/3 of expats. And it's divided into 6 governorates. Each governorate have a school oral health program, and for those school oral health program, goals, objectives, and structure, to have an idea about how the school-based intervention made and the constituents. So I'll go through, just before going through the objectives, the School Oral Health Program was established in 1982 as a pilot program, and then we have very small program in the capital area. And after that, we have 2 initiatives, one in capital program and the other one in Farwania, with 2 different school of thoughts, like one with the joint venture with Foresight Institute, and the other one with the Royal Denmark of Copenhagen University. So we have something from the Scandinavian and something from North America. And unfortunately, after the war, we had to expand. Sorry, so just let me go back. Oh, it's not, so no worries. What we have done there, that after the invasion of Kuwait, the need of the population made the government to expand the school oral health program, which I can say that is OHP all over Kuwait. And then we have different initiatives. In 1994, we had the Kentucky University, Copenhagen, Foresight, and the national program. And after that, they decided to standardize the service and have it all under the umbrella of Foresight and Ministry of Health. And from them, we can have it was like 1999, 2000 time. And 2004, they have decided to have more intensive prevention program. And when I say more intensive, they invested in the infrastructure and changed the protocol. So our objectives were, they established this objective 2004, and it was mainly around the primary stakeholders. We intended to have more children benefiting from the program every year, enhance the awareness among the children, parents, and teachers, and increase caries-free children in permanent and primary teeth, reduce the number of children with unmet need. So this is a bunch of objectives that made us put questions around it in order to evaluate the program. So who's our stakeholders? The main target population is the primary school children, the KGs for prevention, and more treatment services for the intermediate. And we have program managers and staff. There are one key factors that we have to deal with. policy and decision makers and funders. It is, as I mentioned earlier, it's a joint venture between Kuwait Ministry of Health and Foresight Institute. Of course, Ministry of Finance, they have a role in this, and the Bureau in Kuwait. And there are contextual stakeholders. When I say contextual, those who are not benefiting from the program, yet they are partners and active partners in somehow. So this is the logic model. Sorry for the busy slide, but this is the logic model. It's about the theory behind the program. You know, the logic behind using specific resources to have specific activities in order to have an output and outcome. For example, if we take the fissure sealants, we have to have like providers. The providers needs infrastructure and of course budget, and we have to deal with our partners, the Ministry of Education, and we have to have good maintenance group in order to move the mobile clinics from school to school, and you know, all of this just to have a sealant on the top of molar teeth, and then we'll have an increased number of children with fissure sealant that will reduce the DMF, and then it's gonna have a good impact on the quality of life. So this is one example of how the logic model works. So what about the structure? I call it the kitchen is the decision makers. And the decision makers provide the regulation and policies through 5 main departments: education and prevention, training and research, inventory, and 6 programs, each program in one governorate. And if we want to take like an example as a capital, because I was in the capital, and when I wanted to do an evaluation, I chose the capital governorate to do the evaluation. So the program per se, they do have like a clinical supervisor, head of program, education and prevention team leaders. And each of them, they have their own team. And why do we need evaluation? Actually, all of these years, we counted on surveys. And you know that surveys is a cross-sectional study that shows the prevalence of the disease, nothing related to the circumstances or the underlying issues. So why evaluation? Evaluation is to understand the process of learning, how the program is implemented, how well the short and long-term impact. Evaluation is, if you look at the evaluation part in the dental literature, you'll find very poor design, unfortunately, and underreported area. Published report mostly focus on the discrete part of the program. As I mentioned yesterday, we published many papers in school oral health regarding the fissure sealant or the education part, or we have like a retention and using primer on bond or not. But if we missed the whole thing. We missed that it is a community-based intervention, and when we have to evaluate it, we have to look at it as a whole, as a unit, a whole community level, as Dr. Al-Bandari mentioned earlier, how to tackle things from individual to policy making. So my research is about, it's an example or a practice for what she was mentioned this morning. So why we need, when we need evaluation. In the beginning of, the young generation here, they've been taught and how to recognize disease and how to deal with this disease. And after a while, they said, you know what? I noticed that, with specific group of people, this is not gonna work. and they build it, sometimes evidence-based, and sometimes they take it as a personal experience. But we need to do evaluation in the beginning to understand the magnitude of the problem. And when we have a problem and all of us realize that there is a problem and we have to tackle it, we will think about the program. And then another type of evaluation is going to be like evaluating the program content. And after that, okay, we have evidence-based intervention, and we have to tackle this problem from medical or dental point of view. What about the implementation? How well is the program implemented? Because yesterday, during my lecture, this is the bright side of the program. We have a very solid and very comprehensive program. We have 800 people work in this program, and we have 195 dentists with 400 nurses. They are doing it in the school-based clinics as well as clinical center-based clinics. But how well is delivery? We did not, check before. And what we used to do, an outcome evaluation. And mostly in the literature, you'll find that 70% of the evaluation research on impact or outcome. But, they enlist degree in implementation or need assessment. And of course, we should not forget about how efficient is the program. And this is type of evaluation. You have to take it to the Ministry of Health. And then you will talk their language. How much, how effective, and whether it is efficient or not, cost benefit or cost effective thing. And what about the types? As I mentioned earlier, the program design, and it should be like type of need assessment that we'll do need assessment, then we will do a program design. And then we have two types of implementation evaluation, which is we are evaluating the input. Are we putting enough resources in there? And what about the output of this activities? Is it matching our theory or not? What about the outcomes and impact? Which the outcomes usually, it's like when we say that 70% or 1.1 of the children have fissure sealant. But what about the impact of this? Do we have lower DMFT? Maybe, you will have a proximal surface key rates. So it is not affecting the DMFT, but you protected the occlusal part. So it's two different things. And cost effective, actually after all of these years, we were there since 1983, we have only 1 or 2 cost effective, because they consider Kuwait as a rich country. Money is not an issue. But now we are facing, على قولتهم احنا داخلين بالطوفة الحين. فلازم we have to reevaluate, we have to reconsider how we are going to spend our money. So how relevant my research? I remember دكتور عبد الله الشمري الله يذكره بالخير، هو مو موجود بس ملائكته حاضرين. كان in one of the GCC meeting he said, okay, you've been there since 1983 and you are putting great resources in this. What did you manage to lower or reduce the DMF? And one of my superior, Dr. Sabiha Mtawa, she was the former director of dental the department. She came once when we were trying to develop a policy for changing from varnish to changing from fluoride gel to fluoride varnish, and we are putting all the evidence and trying to find evidence-based for this policy. And she said, you know what, not everything can working in the state will work here. And I said, oh my God, we spent all this time in evidence-based classes and lectures, and then they say it's not gonna work. So it's a bit of challenging, like how the superiors look at the things, and you will find some wisdom in there. And that was the main triggers for me, because when they said nothing, not everything works in there will work in the context of Kuwait, I said, oh my God, because we are different. And then I realized they are right. We spend during my PhD training 4 hours just studying contextualism and how it's going to affect your community intervention program. So it is important part. The evaluation is really important, and even the WHO recommend that 10% of the budget should go to the evaluation. And the evaluation, as Dr. Al-Bandari mentioned earlier, it's gonna show the underlying issues. Like, an example, if you see the logic model, it's gonna be the resources you are using, it's gonna yield of outcome or output, and output gonna, have an outcome. But remember the X-ray, since all of us here are dentists, that is two-dimensional. There is another dimension we cannot see. That's why you're using CPCT right now. So we have to identify the underlying issues, and we have to look at our strategies, the policies. Things worked in the 90s, it's not necessarily going to work these days. And one of the things that is really important is to disseminate knowledge about dental public health evaluation. And this is what we are doing here, right? We are sharing our experience with you. So upon the objectives, my research questions were made. I wanted to know whether the school oral health program children have the same oral health status as non-school oral health, and whether they do have better oral health quality of life. And since mothers, they are the second target population, and with the teachers, we wanted to know whether they have better knowledge, they have the awareness that we are doing is good or not. Since we have we adopted knowledge, attitude, practice model, is it good enough or not? And if we are not reaching the objectives or goals, why? What's the underlying issues that, whether facilitating or impeding the implementation? And the big question for me was, after all these years, if it's not a good program, why it's sustained more than 30 years? So all of this question a bit, have a political background, but it was like, a challenge for us. So we decided to have the outcome evaluation to get an information and an insight about the impact of the program on children's oral health. And then we had an implementation evaluation, which is to examine the extent to which the intervention is implemented as planned. Because we have very nice plans, and I know that now you have 2030, but what about the process, the strategies, the small details? I mean, this is the most important. I think, I'm not feminist, but women will look at these things more often than men. So the evaluation research projects was I used 2 types, quantitative and qualitative. Quantitative to understand the magnitude, the qualitative to understand the underlying issues. And qualitative research usually used to study the social determinant that Dr. Al-Bandari mentioned earlier. She said it's not easy to do that because we are not trained to do that. We are dentists. We do like to see our result there and then. So the first phase was cross-sectional study, and the second, focused ethnography. And the focused ethnography is an applied ethnography research that has been widely used in the investigation of investigating specific field with contemporary society, which is socially and culturally highly differentiated. من الآخر هو الethnography, you are studying the behavior of the community, but it is a long process. So focused ethnography usually used in the nursing and community-based intervention for a specific field as a school-based intervention, or you can understand, for example, how the perception of dentists about delivering the system through different setting, like a school setting. So in these two projects were part of ecological health model that Dr. Al-Bandari mentioned earlier, and I'll put it to detect the oral determinant of health. And I used the RE-AIM as well. And RE-AIM model, it has 5 components. RE-AIM, R stands for reach, effectiveness, implementation, adoption, and framework and maintenance. And usually this model used in the public health more often, and to detect the efficiency and effectiveness. Usually, policymakers ask for such kind of study. So this is the ecological health model that I have used, and Dr. Al-Bandari mentioned earlier that we have the individual and the determinants of individual, something we cannot change, like sex, age, and genetics. And then we have a child level influence, like dental insurance, dental access to care, another use of dental care, because Kuwait provide free dental care for everybody. But what about the access to that? Do they benefit from this care or not? What's the barriers? We think that, economic barrier or, other barriers like distance, access to care, but we don't know actually, because we are translating our evidence from international to local setting. Family level influence, and in this study I used family composition and health status of parents, and I chose mothers actually because they are the main caregivers. And in the community level influencers, we have the school-based intervention, which is accessible to more than 300,000 children. So in the first phase, it was like purely quantitative, checking the quality of life, oral health examination of the children, knowledge, attitude, practice questionnaires for mothers, and after that we have the result, analyzed it, look at the trend, the associated factors, and after that we took it to the second phase, which is implementation and maintenance. And then we have all the information, trying to put the puzzle together, and believe me, it wasn't easy. Although I work in the school oral health more than 15 years, but sometimes I get the puzzle part and I try to push it there. It should be fit, but it doesn't fit. So we have to look at the things from different dimension, different direction, with others, other experts' eyes. So this is the phase 1 study, the cross-sectional, and we have more than 440 mother-child pair, and we had the trend of the DMF, oral health quality of life, the knowledge, and the predictors. And in the second phase was the focus ethnography. We have focus groups with the providers, with the key persons and key informants from the schools and the Ministry of Education, as well as 4 in-depth interviews with the policymakers. And it was a great challenge. Actually, it wasn't easy to have the policymakers on board, telling them that I will have this interview and then everything gonna be anonymous. Come on, it's when you say policymakers, your policymakers, right? It was like a challenge how to convince them this is not a judgmental research. We need to develop, to improve. We have to change things. And then when you look at things from their perspectives, their time, you will put a great appreciation to what they have done all of these years. Although, and if you get like a young graduate, you say, we have to do this. We learned this in the state or in UK. And we have to implement the system in Sweden, or the Scandinavian system is really a good model for us. But then it is, when you do the research in detail, you appreciate what they have done. How did they take the decision back then? And we may do the same, actually. So integrating the quantitative and qualitative in order to have an insight and better understanding of the journey. And now I'll have the result. So the first part, I told you I want to examine the reach of the school-based intervention. And I found that 90% of children gave positive consent. So this is a thumb up because people trust the school oral health program. And yesterday I just had a graph when in 2006 we have 46% of children gave positive consent. In 2012 we have 92. And how we achieved this inclination was to institute the consent form in the registration in the Ministry of Education. So whenever you go and you just want to register your kid in the school you will have the consent of school-based intervention or school oral health program. So parents sign it there, and it actually works well because a great effort been invested in the consents before, but now we have 90%. We are talking about 90% we should provide service to. So it's a challenge. And another way we calculated the reach, that what's the proportion of children received the service. And this is what's shocking for us, because 30% received the service. So imagine 70% don't, when I say they received the service, received education and one type of prevention. And if they are eligible for sealant, or sometimes it's not. So again, we are reaching 90%, but we could not, we just covered 30%. So this is how I calculated, we have the, personals from capital. And again, this is a capital. I took a capital as a unit. And we calculated the number of children, and then we excluded those dentists were not involved in the prevention program, and they, usually because we have center-based and school-based, so only 25% of the staff were happy to participate in the prevention activities. This was another challenge. We did not look at it, although we heard it verbally from the clinical supervisors, from the head of programs. I used to be there, and it was a challenge how to motivate young dentists to be involved in this. And at the end, we found out that 30% have been covered. So 70% and 75% of the staff were not involved in the prevention. So when we went to effectiveness, because we had the cross-sectional research project, so it was an impact. And we found out that improvement of oral health status among enrolled and non-enrolled, and improvement in the oral health knowledge among the two groups. And what we found that, children enrolled in school oral health, they have, this is in general that children who said their overall health was affected, they have higher DMF. So this is logic. It's not surprising. And it's the same for DT and the restorative care index, as well as the black index. Although the black index, the oral hygiene, we detected a difference, but not, it is statistically significant, but not of a clinical, significant. So another thing that related to demographics and oral health quality of life, we found that mothers with higher degree and mothers with degree less than the high school, their children have higher DMF-T. So when we looked at the two things, like how come that the higher the highly educated mom and not so lucky to have education, they have the same DMF-T. We found that DT among lower education mothers and FT among higher education. So maybe they are overdoing it, right? And we found out that emotional and well-being was a significant between genders, and this is expected, right? البنات شوية دلوعين يعني. Mother age was one of the factors that related to overall oral health self-evaluation. We found that children who their mothers were of age of 40 and over, they have better oral health status, or this is self-reporting. And this is children meets and measures oral health quality of life according to school oral health and non-school oral health. And we found that there is a difference. And it is a significant difference, like 1.4 DT among school oral health program children, where it is 2.6 for non-school oral health. So there is a difference. But why we did not detect this difference before? Because we used the survey as an indicator. And when we say survey, it's a cross-sectional, having all children, school and non-school oral health program were enrolled. But nothing regarding oral health quality of life. Although I used the validated measure, CPQ, and it was validated in Saudi Arabia. I think this is the most significant table for us in school oral health. And because it's a multilinear regression analysis, we'll find that DMF, the enrollment in school oral health related to DMF, DT, and number of sealant. That means that we have a positive impact. But is it enough? Does this impact, fulfill our satisfaction? It's, if you hear, our colleagues actually in the school oral health and the Ministry of Health, they say, come on, you've been there since 1983 and children been in the school as a patient. Now they are a dentist with you. You should do much better than this. And that makes us to feel, why we are still taking baby steps. One of the things we have discovered, the reach thing, and the second thing, the adoption. And the adoption, I have just looked at it as again, it was like 25% of dentists or staff being involved in the prevention. This is something really, really difficult, for us, how to motivate the staff. The other thing that of the adoption, that 100% of schools, they adopted our services and they welcomed our staff, but the variation within the schools were different. Like the variation ranged from 30 to 100%. So we visited the school, and it is in the productivity, but within the school, did we cover all the children? Sometimes we only covered 30%. And this is something we will not find out if we don't have like very thorough productivity. And imagine, this is one governorate. Imagine if we were going to do it for more than 300 schools. So in the second phase, which is the implementation, that been explored by the influence to which extent the program activities were implemented as intended in the real world, because in the protocol it's nicely fit, snugly smart, and evidence-based. But what about in the real world? Investigating how there was a variation, why some schools we have covered 30% and some schools we have covered 100%. And this thing, you cannot find it in the quantitative research only. So this is the framework. We found out that we have two sets of barriers, obstacles. One related to the program per se, and the other one related to the external factors. The program per se, we are talking about the protocol. Okay, we have an example. We have a school with 500 children. You have to have like a mobile unit for 2 months in order to cover them with sealants. And when they go there, they found that the children not eligible for sealants. They are, they need more treatment services than sealant. And when we want to shift from one school to another, we have to manage with the Ministry of Education and the school schedule, and they are not always cooperative. So we have something related to protocol, the feasibility, and the alternative plan. Once we had the H1N1 epidemic, and they stopped us from having children. So how to deal with this situation? We have a personnel they have to visit, and we have schedule, and it is tight schedule. And one of the things that we were facing, the absentee rate. I don't know how is it in Saudi, but in Kuwait, like we have like more than 50% absentee rate in the kindergarten. So this is again resources that we are investing in somewhere, but we are not getting the benefit of it. The external context, school environment, the involvement, some of schools, they were very cooperative, and sometimes they are passive. And this led the team leaders, like when we say you have to cover this area with the fluoride varnish and sealant, they will choose the most cooperative administration in the schools. We don't want to go to this school because, their principal, they are not welcoming us. So it's not necessarily the needed population receiving the proper service. And beneficiaries, stakeholders, children compliance. One of the things that I asked yesterday, Dr. Muhammad in Germany, what about the compliance of the patients, how they are doing? Is it good or not? Because we have canteens, we access to cryogenic food. Also, teachers, they have agenda, they have priority, they have to go through it, and they have to fulfill the requirements. So, and the last part, which is the maintenance. The maintenance about how the program institutionalized and whether the policy is sustained, modified, discontinued. And we used to have like more than 150 school-based clinics, but now we have only 90, and we have 40 mobile clinics. So some modification being done regarding the policy. And why? Because of the obstacles. And when I checked the maintenance, I found that in the initiation phase, it was based on public health intervention policies. It was very solid. We have very good leadership champions, because that time the minister was public health person. And he was into this, and he motivated the program, and he had the qualification. And they did it all, under the requirement and principles of public health policy and principles. Sorry for having extra time, but again, when you look at these 5 components, reach, effectiveness, implementation, adoption, and maintenance, all is going to give you a better insight about, how decisions were made, how things were being changed. It's all according to community need and population need based. Sorry for having extra time.
Okay, thank you for your very informative presentation, Doctor. But since we're running behind schedule, there isn't any time for questions. So on behalf of the organizing committee, we would like to award you this certificate of appreciation.
Our last speaker for this morning's session is Dr. Abir Sbeit. I'm very pleased to present Dr. Abir. She's a consultant in advanced general dentistry in King Abdulaziz Medical City Ministry of National Guard. She got her master's degree in public health from King Saud bin Abdulaziz University for Health Science. She's a lecturer in the College of Dentistry in King Saud bin Abdulaziz University for Health Science, and currently she's the director of School Dental Prevention Program in Health Affairs. She participated in many social, educational, oral health campaigns activity, and also published multiple articles. Knowing her personally and working with her in the National Guard Hospital, I would add, she's not only a workaholic person, she is very ambitious, enthusiastic. Actually, she's the one who implemented the school health program that is doing very well, and it is a step toward a national school health program. Please welcome Dr. Abir.
Okay, Bismillah ar-Rahman ar-Rahim. I would like first to thank Dr. Mohammed Dosari, the chairman for the scientific committee, for inviting me to give this lecture in this conference and to explain our experience in the National Guard Health Affair in the oral health program. As we all know, WHO in 1948 defined health as a complete state of physical, social, and mental well-being, and not merely absence of the disease. And this biopsychosocial model changed the previous concept of health oriented merely by disease. As we all know, the dental care is a chronic disease in all over the world. And there is a good definition by by an American surgeon, Dr. David. He explained care as a silent epidemic of dental and oral disease burden some population groups. I do agree with Dr. Margaret when he said that oral health is a neglected area of international health. As part of the world, as part of this world, what happened in other countries differently, we have the same problem. So dental caries is a very chronic disease in our country, and this figure shows the mean DMFT for the 6 years children in the GCC countries, and you can see that Saudi Arabia has the highest mean DMFT. This figure shows also the prevalence of dental caries in 12 years old children in the GCC, and again Saudi Arabia has the highest, which is like 92%. The D ratio for the DMFT for the 12 years old children in the GCC countries, again Saudi Arabia has the highest rank and reached 92%, followed by Bahrain 89%, then Oman 76%, UAE 71%, and Kuwait 64%. So just to give a little bit idea about Kingdom of Saudi Arabia demographic data, the last statistic, the total population was almost like 32 million. The Saudi population represents 67.3%, and non-Saudi population represent 32.7%. The children below 5 years old about 10.3%, and the children below 15 years old are about 29.5%. And the population for 65 years old and above 2.9%, and we can see here the majority of the population, they are young population. So we'll talk now about the journey of the dental cares in Saudi Arabia. This is study in 1980s. There's many studies done, but I found this study by Dr. Yunus. He mentioned that there's a low caries prevalence among Saudi children. Another study done by Dr. Skate, he found that 32% of school children were caries free. Going to 19th centuries, there's a study done by Dr. Shammeri. He showed that 23% of 6 years old were caries free. And in continuing with the 19th century, a study done by Dr. Tamim in Al-Madina, and he showed that the DMFT for 6 years old children is 6.4, and for 12 years old is 2.3. Going to 20th century, there's a survey done by Dr. Bnayan in Riyadh area, and he showed that the caries prevalence was very high and reaching 99.3%. Another study done by Dr. Sadhan, and he showed that DMFT for 6 to 7 years old was 7.34. There is a lot of study shows the prevalence of caries and DMFT for the primary dentition of children of age between 3 to 7 years old in Saudi Arabia between 1985 and 2010. And we can see the trend for the DMFT score is going high, and with the prevalence of dental caries is going very high. We all know that tooth decay is 90% preventable through reducing sugar consumptions, frequent exposure to fluoride, routine visit to dentist, and regular brushing. And concentrating about regular brushing here because we know that this habit is not applicable very well by the children. This is a study done by Dr. Doser. He shows that less than 50% of the children, they are brushing their teeth in Riyadh area and Qasim area less than twice daily. Another study done by me, it shows that 66.5% reported brushing their teeth daily, and more than half participants were not using any dental floss and mouth rinses. So all we do agree that prevention is the key for health. And to improve the oral health outcome, we have to have an oral health program in combination with the oral health policies. So in the National Guard Health Affairs, we think to have an oral health program. We named it School Dental Prevention Program. This program it's a comprehensive oral health program serving to the oral health needs of National Guard school children. And the program started in 2007 as a result of a number of studies carried out by the researchers on oral health needs of school prevention program. I'll give you just briefly talk about the National Guard Health Affairs. Is one of the largest health organizations in the kingdom, providing modern medical care to National Guard employees and their dependents with primary, secondary, and tertiary health problems. Under this umbrella of the National Guard Health Affairs, there are 4 hospitals and 60 primary and secondary health centers around the kingdom. The total population for the National Guard is around 350,000 distributed among the Saudi Arabia. While talking specifically in Riyadh area, it's the population around 60,000, and the total number of schools is 60, and total number of students around 24,000. The target population for the school dental prevention program, all the children aged between 6 to 12 years old, and there's 13 elementary schools for boys and the same for girls, and the total target population is around 9,500 students. It's distributed in 5 zones. This figure shows the distribution for the zones with the number of the schools, and this is our target number. So the goal of our program is to achieve optimal oral health to the National Guard school children by a comprehensive oral care approach, education, prevention, and treatment. And definitely we have a list of our objectives to increase the proportion of children benefiting from our program by 10% every year, and to reduce the proportion of first, second, and third grade of children with untreated dental decay to 10% in 5 years, to reduce the proportion of first, second, and third grade of children with untreated dental decay by 90% in 5 years. Also to increase the proportion of children receiving preventive oral health care every year to achieve 90% coverage with the preventive by the year of 2018 for all grades, and to increase the proportion of first, second, and third grade of children receiving fissure sealants up to 90% in 5 years, and increase the awareness about the importance for oral health among school children, parents, and teachers. This figure shows the program implementation step-by-step process. We started the infrastructure development. We set our outcome and objectives. We designed the program. We set the policies and regulations. We start to implement the program, and we have the evaluation for our goals, mission, and outcome. If we need any modification, then we can modify it in order to achieve our goals. In the implementation phase, we have 3 phases. The first phase, it was between September to October 2007, and in this phase we prepared the forms, the pamphlets, or the education materials. And in second phase, which done between October 2007 to April 2008, where initially and during the first year of the program, 1,927 students for the first, second, third grade students were seen. And in this phase, we want to have a baseline of the oral health of school children in National Guard, and the DMFT score at that time was 6.3. Then we go to the third phase, which is the intervention phase. In the intervention phase, we have three performs: health education promotion, preventive measure, and treatment measures. So the objectives for the health education form is to create awareness about the importance of oral health, also to nutritional counseling to increase the patient's awareness of how he can achieve optimal oral health through healthy nutrition. Also to develop sound knowledge about the cause of tooth decay and the loss of supporting gingival and periodontal tissue, improving personal oral hygiene practice, and increasing awareness about the activities of program, which in turn will contribute to the success of prevention and treatment programs. We do a lot of lectures to parents, to school children, and to school teachers, and concentrating on the importance of the oral health. We do health education session to students, and we are doing regular supervised toothbrushing. We did and we prepared a lot of educational aids like PowerPoint presentations, models, videotapes, DVDs, brochures, posters. Then going to third phase, which is the preventive phase. In this phase, once a year, we applied fluoride varnish to all children. We do sealants targeting newly erupted permanent molar and premolars, oral prophylaxis. And initially, during the first year of the program, 1,108 students received pit and fissure sealants and fluoride application. For this, the school dental prevention program has 2 components, the mobile dental clinics and the specialized dental clinics. And each mobile dental clinics has 2 dental clinics, and each mobile has 1 team supervisor, 2 staff dentists, 1 hygienist, 2 dental assistant, and 1 driver. The specialized clinic, we treat patient or students, they were referred to this clinic because if they are uncooperative or need pulpotomies, stainless steel crowns, they need root canal treatment for the permanent teeth, and usually we are doing recall visits for the students in this clinic. I'll show you how we start the steps for the school dental prevention program. At the beginning, usually we have an yearly plan, which we are working in the academic year, and this is an yearly plan for the boys and for boys and girls schools. And we mention here how length we get to stay in each school. We communicate with school manager in order to provide us with the number of students that be seen and their grades, and we inform them for our length of stay, and we give them the consent form to give it to the parents, and we are returning back this consent form from the school manager. This is the consent form. It's one page, but it has two-sided. The first side has the student name, his medical record number, the National Guard, that the parent, they are accepting that we are treating their children in the school, and the other face has the demographic data for the child and his parents' socioeconomic status, and if he is going to dentist frequently or not, and some more informations. In the first day, usually in the mobile clinic, we are doing examination and we are educating children, and then we give follow-up appointment for the next day in the mobile dental clinic and the best care system. This is an electronic system we are using in the National Guard. It's connected to the hospital. We are giving educational lecture weekly and given by the hygienist, and all unfinished cases or cases need extensive treatment where they refer to specialized clinic. The procedures done by dentists in the mobile vans, all the dentists, they are examining all target children, they are filling the children records, they are scoring DMFT and PUFA, and doing emergency treatment for all children. They are doing prophylaxis, scaling if needed, simple restorations for primary and permanent teeth, and they do refer cases for specialized clinic according to referral criteria. I will mention it later. And they are working quadrant dentistry in the mobile clinic, and they document all the procedures in the electronic files in the best care system. Thanks God, we had a lot of achievements. First of all, I'll talk about the statistic achievements. Between 2008 and 2015, 6,786 students were treated in the mobile vans, and more than 30,000 students were seen and treated in specialized dental clinic. This figure shows the statistic for the mobile dental clinic, and we can see that the referred cases are more because in this phase we are concentrating more on preventive phase, not treatment phase. Between 2015 and 2016, the number of students seen and treated in mobile clinic were 722, and the number of visits for specialized dental clinic were 4,543 visits. This figure shows the procedures done in mobile clinic by the dentist. Okay, and between 2016 and 2017, the number of cases or children seen and treated in mobile clinic was 1,199, and more than 4,500 visits were done in the specialized dental clinic. This shows how much we have a D score among our school children, and we can see it's very high among male and female students. We do follow up, and we are treating students till grade number 6. These are the criteria when the dentist referred the patient to the specialized clinic. If the patient or the student is medical compromised or need full mouth rehab, if the patient needs extractions, pulpotomies, or uncooperative patient or unfinished cases. We start also, beside to record the DMFT score, we record the PUFA score, because we've realized that there's no studies have been conducted in Saudi Arabia to assess the reliability of PUFA, which is pulp, ulcer, fistula, and abscess index. And PUFA is an index used to assess the presence of oral condition resulting from untreated caries teeth. Here shows the PUFA score for male and female between 2015 and 2016, and shows that the pulpal involvement is very high, and it's more among male than female. And we can see here that much more pulpal involvement it's in school children, and that means all these need the root canal treatment in the future. in order to address our achievements, I just took like a follow-up group just to make with them a follow-up visits and recalls in order to know where we go during our treatment in the program. So we took a sample group from our population. I took 68 male students and 94 female students. We did follow-up appointments between 2014 and 2017, and we discovered that the D ratio for this group was reduced by 33%. Then it comes to our mind why we don't calculate it financially to see how much is it cost effectiveness. And then I did simple calculation based on a study done by Dr. Al-Marghalani. He assumed that if each child has DMFT score with 6, and the cost will be 600 riyal, and if the prevalence was 74%, so the number of affected children will be more than 5 million, and the cost it will be around 4 million riyals. And once the prevalence increases, the cost definitely will be increased. So based on that, I have my targets 9,500 children with the prevalence of dental care is around 96%, and the yearly cost will be around 5 million, more than 5 million riyals. With the 33% reduction, we can save up to 2 million riyals from our budget. So we can understand that the prevention is more cost effectiveness than cure. One of our achievements, we are the first program in the Middle East. We issued the Braille brochure for oral health education. And before 2 weeks ago, we visited a Noor school for the blind student in cooperation with the interns in the College of Dentistry and King Saud University for Health Science, and it was a very successful visit. The interns deal with blind students by TIL and do method. Also, more than 20,000 children were benefited from the different activities of the program at the age of group 6 to 11 years in cooperation with the COD or the college dentist college students and interns. So the conclusion of my lecture that more oral health programs must be deployed to attempt to control oral disease, and school-based approach should be combined with family and community preventive programs. High number of untreated cares and school children require immediate attention. Thanks God, dental caries is both curable and preventable, and therefore should be given the priority and the full resources. But we do agree on all these conclusions, but definitely we have a problem that we have inadequacy in our prevention programs, and unfortunately, despite the expense of different preventive programs, progress towards reducing dental cares and periodontal disease are very low in Saudi Arabia. We have a lot of scattered effort that into a lot of waste resources, and we have poor coordination between the different related governmental sectors, and we have a lack of achievable goals and measurable objectives, and it's more toward promotion rather than intervention. As we all agree that with the new vision of Saudi Arabia, with the Vision 2030, there's a lot of aims. One of the main aims is to provide education that builds our children's fundamental characteristics and establish empowering health and social care systems. And they mentioned that the public sector will focus on promoting preventive care, on reducing infectious disease, and encouraging citizens to make use of primary care as a first step. And I think in the National Guard Health Affairs, we are almost in this stage for promoting preventive measure care. So I think from my point, the solution, we need one national structural preventive program with a long-term vision, clear achievable goals, and measurable objectives to be governed by an independent executive institution council. And at the end, I want to thank you everyone for your attending and listening to my lecture. Thank you.
Thank you, Dr. Abir, for this very informative presentation. and a very promising healthcare project. I really hope that it's a step toward a national school preventive program. Thank you so much. On behalf of the organizing committee, we would like to give you a sign of gratitude and appreciation. Thank you, Dr. Abir.
Thank you very much for the speakers and chairperson for addressing this interesting topic. On behalf of our organization committee of Riyadh Dental Meeting, we would like to present the chairperson with these gifts. Dr. Samar Al-Hayek. and Dr. Uhud Al-Harthi. Ladies and gentlemen, we come to the end of our morning session. Thank you for your attention, and hopefully the presentation will be beneficial for everybody. And now we will have a prayer and lunch break, and we will come to start the afternoon session at 12:45. Thank you.
اتوقع يوم تبدا الليكتشر بتكون اضاءه زينه.
مايك تيست. طيب انت حتبدا من هنا؟
اي هذا كامل.
اوكي وبعدين؟
كامل هذا خلاص كامل.
لا انت حتقدم هذه وبعدين حتقول هي بريزنت مودرن كيرز. ناو ليتس ويلكم ليتس ويلكم دكتور اسيستنت بروفيسور دكتور محمد الكلزي. He will present modern cares prevention at group level كده.
اي بالضبط.
لا بس كده انا ما شايف انها. خلينا نشوف. حنقول our next speaker in this afternoon. Our speaker in this afternoon أول شيء good afternoon everybody. We will start this afternoon with Assistant Professor Dr. Mohammed Al-Kilzi. Dr. Al-Kilzi graduated in 1997. الصوت واضح؟
لا.
جميل. لازم نقرب شوي. Good afternoon everybody. Let's welcome Dr. Al-Kilzi. Dr. Al-Kilzi, good afternoon everybody. Assistant Professor Dr. Mohammed Al-Kilzi will present modern cares prevention at the group level, a Greifswald concept for practice settings. Dr. Al-Kilzi graduated in 1997 from the University of Aleppo. He specialized in pediatric dentistry in the University of Damascus in year 2000 and from the University of Greifswald in year 2007. In 2009, he obtained a PhD in Department of Preventive and Pediatric Dentistry of the University of Greifswald. In 2013, he has taken up the position of Associate Professor in the Department of Preventive and Pediatric Dentistry, Center for Oral Health. University of Medicine, Greifswald in Germany. Besides his involvement in educating under and postgraduate students, he is leading many research projects in preventive and pediatric dentistry. Dr. Al-Kilzi has published many scientific articles in English, German, and Arabic. He also participated in editing some books in pediatric dentistry and cardiology. His point of interest is improving oral health in children and adolescents.